Hello, I'm Infection Control Nurse of Changhua Christian Hospital. My name is Huei. The topic of today is prevention of catheter-associated urinary tract infections. I will explain based on guidelines for prevention of catheter-associated urinary tract infections, published by the Healthcare Infection Control Practice Advisory Committee in the United States. Recommendation is categorized according to different levels of evidence. Summary of recommendations. First one is appropriate urinary catheter use. Insert catheters only for appropriate indications and leave in place only as long as needed. Minimize urinary catheter use and the duration of use in all patients. Particularly, those are higher risk for COTI or mortality from catheterization, such as women, the elderly, and the patient with impaired immunity. Use urinary catheters in operative patients only as necessary rather than routinely. For operative patients, remove the catheter as soon as possible post-operatively, preferably within 24 hours, unless there are appropriate indications for continued use. Example of appropriate and inappropriate indications for intervening urethral catheter use. Example of appropriate: patient has acute urinary retention or bladder outlet obstruction. Need for accurate measurement of urinary output in critically ill patients. Perioperative use for selected surgical procedures. To assist in healing of open sacral or perineal wound in incontinence patients. Patient requires prolonged immobilization. To improve comfort for end-of-life care if needed. Example of appropriate: as a substitute for nursing care of a patient or resident with incontinence. As a means of obtaining urine for culture or other diagnostic tests when the patient can voluntarily void. For prolonged post-operative duration without appropriate indications. Proper technique for urinary insertion. Perform hand hygiene immediately before and after insertion or any manipulation of the catheter device or site. Ensure that only proper trained person. In the acute care hospital setting, insert urinary catheter using aseptic technique and sterile equipment. Properly secure intervening catheters after insertion to prevent movement and urethral traction. If intermittent catheterization is used, perform it at regular intervals to prevent bladder overdistension. Proper technique for urinary catheter maintenance. Following aseptic insertion of a urinary catheter, maintain a closed drainage system. If break in aseptic technique, disconnection or leakage occur, replace the catheter and the collecting system. Maintain unobstructed urine flow. Keep the catheter and the collecting tube free from kinking. Keep the collecting bag below the level of the bladder at all times. Do not rest the bag on the floor. Empty the collecting bag regularly using a separate, clean collecting container for each patient. Avoid brushing and prevent contact of the drainage spigot with the non-sterile collecting container. Use standard precaution including the use of glove and gun as appropriate. The wrong approach on the left. It should be prevent contact the gauge spigot with the non-stereo collecting container. Change intervening catheters or gauge bag at a routine, fixed interval is not recommended. Rather, based on clinical indications such as infection, obstruction, or when the closed system is compromised. Unless clinical indications exist, do not use systemic antimicrobial routinely to prevent COTI in patients requiring either short or long-term catheterization. Do not clean the periurethral area with antiseptic to prevent COTI while the catheter is in place. Routine hygiene is appropriate. Unless obstruction is antiseptic, bladder irrigation is not recommended. Routine irrigation of the bladder with antimicrobials is not recommended. If COTI rate is not decreasing after implementing a comprehensive strategy to reduce rate of COTI, consider using antimicrobial antiseptic impregnated catheter. Quality Improvement Program. The purpose of a quality improvement program should be to assure appropriate utilization of catheters, to identify and remove catheters that are no longer needed, and to ensure adherence to hand hygiene and the proper care of catheter. Administrative infrastructure, provision of guidelines, education and training, provide adequate supplies, system of documentation, in the patient record, indications for catheter insertion, date and time of catheter insertion, individual who inserted catheter, and the date and time of catheter removal. Surveillance for COTI. Surveillance. COTI surveillance include number of COTI per 1,000 catheter days, number of bloodstream infections secondary to COTI per 1,000 catheter days, catheter utilization ratio. When performing surveillance for COTI, consider providing regular feedback to unit-specific COTI rate to nursing staff and other appropriate clinical care staff. What is the bundle? IHI developed the concept of bundles to help healthcare providers more reliably deliver the best possible care for patients undergoing particular treatment with inherent risk. A bundle is the structured way of improving the process of care and the patient outcomes. A small, straightforward set of evidence-based practice, generally 3 to 5, that, when performed collectively and reliably, have been proven to improve patient outcomes. Fully bundled experience sharing in our hospital. Share according to the following outline. Training specialists. Specialist education and Foley insertion technology certification. Training specialists use checklists to check the bundle care of Foley insertion and daily care. Information system improvement including the doctor order for Foley insertion, standing order instead of stat order, checking the indication before doctor making orders, recall who operated the Foley insertion, reminded the doctor to remove Foley. Daily catheter assessment in the nursing system. Query the average days of catheter placement in each unit. After catheterization for 48 hours, the system at 11 a.m. will remind the doctor to remove Foley every day. Daily catheter assessment in the nursing system check item included. Review the daily need for catheter. Maintain urine flow unobstructed. Securing catheter at leg abdomen. Collecting back lower the level of the bladder at all times. Hand hygiene before and after every catheter care. Clean the periurethral area. Equipment improvement. The skin disinfection for Foley insertion use 2% aquaseptic chlorhexidine. Change the size of catheter for patient who has urine stagnant, hematuria, BPH, etc. Or after surgery can be inserted 16 French or other size. The rest situation can be inserted 14 French. Urine sample from sampling pot. Expand the aseptic area and pre-connecting catheter and the urine bag. Using bladder scan to reduce Foley insertion times. Monthly feedback to the unit supervisor on the density of catheter-associated urinary tract infection. ICU COTI density downtrend. Conclusion. COTI is a common healthcare-associated infection. Once COTI happens, the patient must be treated with antibiotics and prolongation of stay in the healthcare facility, which means the increase of medical expenditures. Furthermore, multi-drug resistance may happen at the same time, and then there will be no suitable antibiotics for the patient. Length of catheter intervening time is the main risk factor of COTI. Avoid unnecessary catheter placement and carry out care team cooperation to reduce COTI to ensure patient safety and medical quality. Thanks for your attention.